This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard of Cardiology Specialists of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
Welcome to our podcast, the ongoing research and the future of cardiac transplantation. With us today, we have our guest, Dr. Jason Guichard, heart transplant specialist in South Carolina. We have also Dr. David McGiffin, heart transplant specialist and director of the cardiac surgery program at the Alfred Hospital in Australia. Gentlemen, thank you very much for being part of this podcast on heart transplantation.
Morning.
Thank you. So last podcast, we discussed some of the new U.S. donor heart allocation policy, and basically discussed that there were obviously more categories to better stratify medical emergencies and decrease waitlist mortality. We also discussed that ECMO patients receive top priority. We saw also and discussed that the VAD patient and other patients with mechanical circulatory support devices are seen as a viable long-term alternative, of course, albeit if there are no complications. All new policies are reevaluated every 6 months. And it's also, we discussed the change in the principal guiding geographic organ distribution zones around the donor hospital, meaning that if there are no local patient match or there's a sicker patient elsewhere, the heart will be considered by hospitals within 500 to 1,000 miles. Obviously, that brings, a lot of issues, and we had to discuss some of these issues, particularly the stress that it causes on the donor heart, mostly with the ischemic time. And Dr. McGiffin, you had mentioned some of the research that you were doing in that area in Australia. What is possible nowadays, and what are we looking at to protect the donor heart and make it available for patients very, very far away?
This issue is a particular problem in a country the size of Australia, which has a 15th of the population of the United States, but roughly the same surface area of the United States. So we have these enormous distances that donor hearts have to travel. And there are only 5 heart transplant programs in the entire country. So the areas of Australia that are very, very remote that would have donors and the ischemic time, that is the time from when the heart is removed from the donor to when it's beating again in the recipient, can be inordinately long. As we've mentioned on a previous podcast, there is a very clear relationship between increasing probability of primary graft dysfunction, that is, the donor heart doesn't work in the recipient, with increasing ischemic time. And the break point in that curve is around about 4 to 5 hours. And that effect, that phenomena, is magnified by increasing donor age. One of the issues that we have these days in transplantation, and this is a worldwide issue, it's not just Australia, is that the age of donors is increasing. So there's the sort of challenge. Now, that we've been doing some work in Australia on increasing the ischemic time out to at least 9 hours. If we could increase the ischemic time safely to 9 hours without the penalty of primary graft dysfunction, then there is no heart in Australia or New Zealand, because organs can go between Australia and New Zealand. There is no heart that could not be transplanted because of logistic reasons. Now, the next horizon in cardiac transplantation is machine perfusion. Now, we've already seen the TransMedics device being used for DCD hearts, that is, donation after circulatory death. And the TransMedics system is able to resuscitate hearts that are removed in the DCD situation, because DCD hearts take this triple hit of ischemia, of hypoxia, and distension. So they're not normal hearts. They have to be resuscitated, and the transmedic system does that by a warm beating process. And the transmedic system is also used for so-called marginal hearts, where there is a donor heart that had some sort of injury, the injury of brain death and myocardial dysfunction, and potentially could be resuscitated on the transmedic system. So that's dealing with non-normal hearts. Now, if you take a normal heart from a brain dead donor, is there some way that we can machine perfuse this heart to allow the ischemic time to be extended out to 8 to 9 hours? And the answer to that question is yes. And that's the basis of research we're doing in Australia. So the real pioneer of hypothermic ex vivo perfusion, HEVP, is Professor Stig Steen from Lund in Sweden. Stig Steen's a remarkable man. He's a retired cardiac surgeon, but he's got this incredible grasp of physiology. And he made a conceptual leap in HEVP by saying that a heart beating in a brain-dead donor is equivalent to a heart on a machine perfusion system. That is, neither have a functioning vasomotor center or a functioning pituitary gland. So he came up with this perfusion solution that's cold. It's at 8 degrees centigrade. It's got oxygen in it because it does have red cells. It's a cardioplegic solution to pharmacologically paralyze the heart, but it also has brain death hormones in it. It's got thyroid hormones. It's got adrenaline and noradrenaline. It's got corticosteroid, and it also has insulin as well to deal with the issues. So glucose can be taken into the myocardial cells. So we have an experimental model of brain death and machine perfusion, and then transplantation of the heart, and in the experimental animal. And we now routinely can extend the ischemic time out to 9.5 hours with normal function of the donor heart in the recipient. It is one of the most remarkable things I've seen in transplantation, to be able to machine perfuse a heart for 8 hours, then to put it into a recipient with normal function. But it's even more interesting than that. The method that we use worldwide for cardiac transplantation, the method we've used for 50 years, is called cold static storage. So we take out a donor heart, we then put it in an ice slush solution and carry it in a cooler. That's how it's done worldwide. If we do that to an experimental animal heart, and then even for a relatively short time, like about 2 hours, and then we transplant it into a recipient, the hearts do work okay, but the recipient doesn't. So that the urine will often just switch off, the animal will become vasoplegic, and we need a lot of support with inotropic and vasopressor drugs, and the animal may not necessarily survive for the 6 hours of observation period. Whereas if we machine perfuse with HEVP the heart, so we perfuse it in the donor, take the heart, put it on the perfusion system, even for relatively short periods of time, like about 2 hours, and then transplant it into the recipient animal, the heart works normally, but so does the recipient. We get no vasoplegia. The kidneys work and we have minimal inotropic requirements, and the animal survives to the 6 hours of observation. So something comes out of these donor hearts when we store them in with cold static storage. We don't know what it is. That's our next line of investigation. What is it that is damaging to the recipient? But I think HEVP is got tremendous potential. So as a result of the work we're doing and work in Sweden, there was a clinical trial of HEVP with relatively short ischemic times in Sweden, just to demonstrate the safety of HEVP. We are actually we have a Australia-New Zealand trial of which I'm one of the principal investigators, and all 5 transplant centres in Australia and the 1 transplant centre in New Zealand are involved in this trial. We haven't been able. We're ready to go. Unfortunately, we haven't been able to start because of COVID. But the study will involve any donor heart in Australia where the projected ischemic time is greater than 6 hours will be put on a HEVP system. This is the ex vivo system, and then will be transported to the transplant centre. And this will involve 36 donor hearts. So this is a real test of HEVP. The short ischemic times that they used in Sweden demonstrate the system is safe, but that's not the real test. The real test is, let's take the ischemic time out to a duration where we would all have some disquiet, some concern about using cold static storage, and that is beyond 6 hours.
This is very exciting and really fascinating. So you're just about to start clinical trials in patients, in actual transplant patients. This is like a phase 1 or phase 2.
Yeah, this is correct. This is a demonstration of efficacy of the system. The underpinning of this is we would not use these, or we would be very reluctant to use these hearts, or we only use these hearts for somebody really urgent, because we're going beyond 6 hours, where we assume that we may need to use post-op ECMO to support the heart until it recovers. It's with cold static storage.
Fascinating, and possibly could enter a phase 3 clinical trials within the next 2 years.
I think very likely there's a trial that is ready to get underway in Europe, which would be a randomized trial of cold static storage versus HEVP. That trial is difficult because it involves 8 different countries with all their different regulatory differences, particularly with respect to governance and ethics, and it's also been held up by COVID as well.
Right. Anything in South Carolina, Jason, in the field of ischemic time research?
No, not really. Cold static storage is still kind of the gold standard, as Dr. McGiffin knows. And, there are some companies out there, with kind of warm perfusion type devices to improve things, as well as kind of DCD organs and trying to, transport patients to the donor hospital itself, so it reduces ischemia time. But, it's a field that's, has been pretty static, no pun intended, for decades, as Dr. McGiffin alluded to, and definitely has some, probably room for improvement in this kind of new technology age and better understanding of, human physiology that we're in now.
Well, that's great. And we talked a little bit about even the new allocation, the patient that have, VADs, as well as mechanical circulatory support system, considered viable unless they have a complication. And of course, in the complications are described as hemolysis, device infection, the thrombosis or clotting of the pumps, as well as the bleeding. But what kind of options do we have, for example, if the right ventricle doesn't really want to collaborate? Do you want to tell us a little bit more about that, Dr. McGiffin?
Yes, this is one of the problems of LVADs, and that is the right ventricle. It's important to understand some of the physiology of the right ventricle, because the right ventricle relies very much on the function of the left ventricle. So probably at least 20 to 40% of right ventricular ejection is directly the result of left ventricular contraction, particularly the septum and ventricular twist, because the fibers of the left ventricle, are oriented both longitudinally, circularly, and obliquely. And it's the oblique fibers that give the twist to the left ventricle. Now, the right ventricle, though, has only longitudinal and circular fibers, so it's unable to twist. So it relies on the septal contraction and the twisting action of the left ventricle for some of its function. So when we put a VAD in the left ventricle, we change the geometry of the right ventricle and we change its physiology. So because the sewing ring and the inflow cannula is attached to the apex of the left ventricle, we obliterate the twist, most of the twisting action of the left ventricle. And we also distort the septal contraction as well. So it's not surprising then that the right ventricles can fail after implantation of an LVAD. Now, there are patients that we know ahead of time, before LVAD implantation, this right ventricle is going to be a problem. And it's those patients where right ventricular failure is clearly part of the clinical picture. Now, it's a small group of patients, probably about 10% of patients having an LVAD, where we say, this right ventricle has no chance. We've got to do something else, something for that right ventricle. So the options are either a total artificial heart, and the only one that really is on the market at the moment is a Syncardia, or use two LVADs. That is an LVAD in the left-sided position and an off-label use of an LVAD in the right-sided position. So that means two pumps, two drive lines, two sets of batteries, two controllers. It's sort of cumbersome, and the results of doing this are not all that good. And one of the concerns is thrombosis of the right-sided pump, because that appears to be a fairly provocative setting to put a pump on the right side. And it's also raised the question of where should you put it? Should you put it in the right atrium or put it in the right ventricle? Now, there have been at least three that I can think of, three experiences with the hardware pump placed either in the right atrium or the right ventricle. But survival's not all that good. It's about 50% at 12 to 18 months. Now, I will say that I think the HeartMate 3 has made a difference, because we have 12 patients that we've put in a right-sided pump, so it's a biventricular configuration, where we put the HeartMate 3 in the right atrium and as a bridge to transplantation, and we've had one death. And we've bridged one patient to recovery and VAD explantation. We've had the one death, and we've bridged 8 of the patients to transplantation, and 3 are remaining on ongoing support. So I think that this notion that that the results of using BiVADs are not very good is not immutable, because I think we've demonstrated in our HeartMate 3 experience that you actually can get good results. But I think that maybe the HeartMate 3 is the answer here, because the risk of pump thrombosis in the HeartMate 3, we know from the Momentum 3 trial, is almost negligible. And that may, in fact, make the difference. Now, right ventricle, long term though, if you have an LVAD, the right ventricle is even if the patient doesn't need biventricular support up front, we do know that one of the major causes of death after an LVAD is progressive right ventricular failure. So the problem is still not solved. The biventricular support up front, I think we have an answer to that problem, but when the right ventricle starts failing a year from the LVAD, 18 months, 2 years, that patient is on a really bad trajectory. They go downhill very quickly. So the answer is, if you've got an LVAD and you're right, you start getting symptoms and signs of right ventricular failure, you're in bad trouble. And if you're a bridge to transplant, then you need to be transplanted because your survival is very poor. Now, if it's destination therapy, of course, we don't have a good answer. Now, I will say, though, that that this biventricular configuration with 2 LVADs, as I said, it's sort of cumbersome, but you can make it work. I think the future is, though, a fit-for-purpose designed biventricular pump. And there is one that's currently in preclinical testing called the Bivacor. Now, this is a really novel pump. It had its origins in Australia, in Brisbane, and it's very, very clever. So there's one can and 2 impellers, which are very different shapes, one for the left ventricle, one for the right ventricle. So they have their own characteristics based on which circulation they're pumping for, the left side or the right side. And they're on the same shaft. But it's got a movable plate between the 2 impellers, so it's got its own ventricular interdependence. So depending on the filling of one side, it'll move the plate to change filling on the other side. And it can get tremendous flows. So I think a pump like the Bivacor may be the answer, rather than use this sort of cumbersome arrangement of 2 LVADs. So you've got to take out the ventricles. And so these connectors onto the atria, and then they clip into the Bivacor. The syncardia also is very similar. You take the ventricles out, put these cuffs on the atria, and then the syncardia clips into these cuffs. But you can't, if recovery of the myocardium is even possible, then you shouldn't be thinking syncardia or thinking Bivacor. If you want to recover the heart, then you need to be using an LVAD. So drivelines are one of the weak links in ventricular assist devices. The drivelines have to penetrate the skin coming from the pump to the controller and the power source. And you can readily see that these drivelines are a problem because they are prone to infection, because the exit side of the driveline in the skin is a portal of infection. And infection is not driveline infection is not just a local problem of infection. It has important ramifications because in most studies, particularly multivariable studies of risk factors for stroke, either hemorrhagic or ischemic, driveline infection emerges. So there's probably some systemic consequence of having a driveline infection that contributes to ischemic strokes and hemorrhagic strokes. So infection is a very important problem associated with VADs. So what the goal in VAD therapy is to get rid of drivelines. And the VAD companies are working furiously on this because this would be an enormous development. So The future is some sort of transcutaneous energy transfer. So the patient has a coil somewhere in the chest or the abdominal wall, and there is a external coil that is put over the internal coil, and energy is transferred from the external coil to the internal coil. Now, that's sort of in principle, but the details then become important, because making sure that the coils are aligned properly is difficult. There's the problem of conducting heat away. What do you do with generated heat? The reliability of the system, because if the system fails, then the pump stops. So it's got to be 100% reliable. And there is a system called the coplanar energy transfer system, and this has been performed, I think it's in 2 patients so far. So there's a large coil that is placed in the right pleural space beneath the right lung, and the alignment of the exterior coil and the interior coil aren't as critical with this coplanar system. And these patients are free of any driveline. And there's a very interesting video clip I've seen of this patient without a driveline actually getting into a swimming pool and swimming. But one thing to note, there's a wire that's actually running up, attached to the skull, which is the emergency plug-in if the system fails. So reliability is still a problem. So this type of system is probably a few years away yet, but it's the next horizon in VAD therapy, is getting rid of drivelines.
Amazing. A lot of research, obviously, being performed in this mechanical circulatory support devices, and HeartMate 3 and so forth. So a lot of bright future and a lot of development we should expect there. So can we actually, with this in mind, can we actually make a new heart, using the technology that we have nowadays, Jason? How about 3D printing and fabricating a new heart that we could transplant?
Yeah, so there's lots of what is seemingly kind of space age technology and ideas nowadays, with the advancement of various 3D printing and kind of biologic printing, as well as gene editing. So some of the kind of high yield, high technology things that are on the horizon is indeed 3D printing. So being able to have cellular scaffolding for various organs, not necessarily just the heart, but other organs as well, the lungs, the liver, the pancreas. So having a biologic scaffold that mimics the human organ, and then using 3D printing of tissues or stem cells on top of that scaffolding that then remake a biologic organ. As you might imagine, if you use patient cells, then this gets away from the idea of rejection. This would all be something that would be compatible with the recipient. So these are some technologies that once was just hypothetical are now becoming a reality. So as our technology with printing and understanding kind of biologic mechanisms and stem cell activation, I think these will all become a reality in the distant future. Probably something that would be more of a reality in the not too distant future, and Dr. McGiffin would be able to comment on this as well, would be xenotransplantation. So there's been a lot of advancements in xenotransplantation, which is using animal organs and transplanting them into humans. So using gene editing technologies to make animal organs immunologically silent so that they are compatible with humans, or expressing human proteins that at least make them look on the inside that they're compatible with humans, are all things that are advancing quickly. So once, xenotransplantation was, the future and just kind of continued to always be the future. Now it's seemingly like the future is now, potentially, given some of the very rapid advancements in biological technology and gene editing and some of those things. There's a recent article that came out, looking at genetically modified pig hearts and transplanting them into baboons. That was fairly successful. And again, just kind of a preview of potentially things to come. I'd like to get Dr. McGiffin's comments on that as well, because he's lived and breathed this field for decades.
So Norm Shumway, who's the father of cardiac transplantation, once made the statement many years ago, and Jason just alluded to it. Xenotransplantation is just around the corner, and that's where it always will be. That's probably no longer true. There's some really interesting developments in xenotransplantation. Now, it's probably theoretically possible to use non-human primate hearts and transplant them to humans, but that's something that will never, nor should it ever happen, because I just don't think that there's, for all sorts of societal reasons, that would be accepted. So the animal that's really been chosen for xenotransplantation is the pig. And I think probably one of the biggest the area that really needs xenotransplantation is pediatric cardiac transplantation. Having small pig hearts, which would be suitable for infants and children. Now, the problem is there are lots of immunological problems, but the one that became apparent in the early days of xenotransplantation is the fact that on the pig, cell surface is a carbohydrate, galactose 1,3-galactose, and it's on all animal cells except for old world monkeys, which includes humans. But we have antibodies to GAL. We acquired these antibodies early in life, probably from the microbiome in our gut. And so if you put a pig heart into a human or a non-human primate, there'll be immediate hyperacute rejection. So pigs were engineered so they didn't express the GAL epitope, and that sort of gets around the hyperacute rejection problem. But the acute xenotransplant rejection problem also involves coagulation, involves complement activation, and so pigs are being engineered now to have complement regulatory proteins and thrombomodulin, which is a anticoagulation gene. And as Jason alluded, there have been some xeno programs around the world that are getting really very good survival out to a couple of years with pig to baboon. And I will mention there are lots of details which I'm leaving out here. The immunosuppression is very specific for preventing xenograft rejection. But there's a group in Germany, Bethesda, and at UAB that have got a pig to baboon model, and with this very prolonged survival. Now, the 2 years is great, but it's not 10 years. And so there's probably some other forms of rejection and other concerns that haven't yet become apparent. One of the concerns is about transmitting retroviruses too. That concern is probably been overplayed. But I think the field is moving very rapidly, and I think xenotransplantation of pig to human for kidneys and for hearts is a realistic option in the near future.
Certainly, patients are used to getting a pig valve or a bovine valve. So it's not too much fancy to push that forward to really a pig heart, and as maybe a way to to help with transplantation and patients with end-stage heart failure. Still in preclinical studies, so a lot of work to be done, but future is promising there too. Now, if we look at rejection, obviously the patients that have had a transplant and where you want to monitor rejection still have to have these endomyocardial biopsies, repeatedly. Is there something that is being developed in the field using non-invasive technique, or is the cardiac biopsy just the only mechanism to detect rejection? Jason.
So, the heart biopsy is, still kind of the workhorse for ruling out cellular and antibody-mediated rejection in transplant patients, especially in the first year, which is the highest risk kind of period, so to speak, for having rejection. There's been a lot of work into finding what we call non-invasive ways, so not having to do a heart cath, not having to do a biopsy, non-invasive ways of determining rejection. And not a whole lot has been able to be identified to really kind of rule that out. As you might imagine, these are very high stakes. If someone's heart rejects, that's a big deal. To lose a transplanted heart, either immediately or even after even after 1 to 2 or even 3 years. So the stakes are very high. So lots of research going into identifying things, circulating things in the blood to rule out rejection. But work still has to be done. There's been a lot of things looking at, circulating cell-free DNA, various biomarkers, including, BNP, troponin, various growth factors like VEGF or ET1, including some immunologic kind of factors as well, like CD5L, looking again for acute rejection. But ultimately, a lot of those things are still in the experimental stage. The one kind of non-invasive testing that's been used in some parts of the world, including the US, is AlloMap. So AlloMap is kind of a non-invasive test, again, for heart transplant recipients that's able to identify potentially acute cellular rejection in transplanted patients. And it uses a kind of a cluster of 20 genes. So it uses blood to analyze 20 genes to look for the activation of rejection. So this is something that's been used in some centers, not used in others, but is a way of kind of non-invasively detecting rejection. So there's a few indications. We can talk about that, or at least when to think about it. So gene expression profiling can be used as an alternative to endomyocardial biopsy, like we've talked about, for routine rejection surveillance. So this would just be routine. You would never use any of these non-invasive tests in people who are high risk for rejection or actively rejecting. It's most appropriately used to exclude moderate or severe acute cellular rejection in patients between 6 months. So that'd be kind of the earliest time frame, and 5 years post-transplant. So that's where it has FDA indication, although there are some centers that use it even past 5 years, and considered to be a low likelihood of such rejection. So these are your low likelihood patients. You would never use this in people who are high risk for rejection. It's currently indicated for patients at least 55 days from transplants as the FDA indication, on less than 20 milligrams of prednisone daily, with no recent rejection. And recent rejection is defined as rejection or a rejection episode less than 6 months. So this is probably the most robust, in a way, non-invasive test for kind of low-risk patients. But ultimately, and anyone who's gone through a transplant evaluation or is currently transplanted knows that the workhorse of rejection evaluation is indeed the right ventricular biopsy or endomyocardial biopsy, and is usually so for definitely the first year, if not into the after 5 years. And then if everything remains stable after that, then certain centers will have protocols for trying to do non-invasive ways, whether that's dobutamine, stress echo, or AlloMap or other things that makes it a little bit easier for the patient.
Now, the non-invasive imaging techniques, we could see LVH or really hypertrophy, or where the heart muscle becomes very thick on echo. Nothing in the field of the MRI or magnetic resonance imaging with or without gadolinium.
I think there are people looking at that, but I don't think any of the current studies have been solid enough to switch kind of the standard practice patterns. But really, it would be looking at inflammation. So it's really what you're trying to identify with rejection. Is looking for those immune cells that are invading the heart and basically attacking what the cells perceive as being foreign. So you could see that on cardiac MRI as inflammation, kind of non-specific inflammation. And some of those things are, being used currently, but I don't think any of them are kind of ready for prime time.
Dr. McGiffin has mentioned in the first podcast that cyclosporin has been, the immunosuppressive drug that really changed the whole field of cardiac transplantation. Are there any new immunosuppressive therapies that are being studied currently? Maybe something that is more catered to a particular patient or more individualized medicine type?
So there's really there's lots of immunosuppressive drugs that are being studied in the laboratory and in experimental situations, but there's really nothing out there at the moment that is on the horizon to change cardiac transplant immunosuppression. The drugs we've got at the moment, it's good. There's no doubt when CNIs came along, that is cyclosporine and tacrolimus, it just absolutely changed survival. It was just overnight. So the CNIs have been were incredibly important to improving the survival of patients after cardiac transplantation. But there's no next step beyond CNI that's going to result in another dramatic step in transplant survival. The proliferation signal inhibiting drugs, sirolimus and everolimus, they have got an important role under certain circumstances, but they haven't made the big leap that the CNI drugs did.
Yeah, and all that's true. I would say that there are definitely some, the mTOR inhibitors like sirolimus, some big believers. Various centers are kind of big believers in those, and kind of small little studies coming out, looking at the early conversion to sirolimus, at attenuating, cardiac allograft vasculopathy, which is kind of the heart disease equivalent in the transplanted heart. And then some suggestions that maybe there might be a lower mortality and fewer events related to CNI use, but none of these are really, I think, kind of ready for like a wholesale change in the transplant community. I think there's going to have to be additional data and that sort of thing. But I think at least the idea and being open to switching to some of the mTOR inhibitors is there. But Dr. McGiffin suggested, nothing has revolutionized transplant like the CNIs, which is a great thing. Basically, that's kind of changed transplant management, for the last several years. And I want to say the last numbers I saw, about 90 to 95% of programs are using calcium urine inhibitors, which is impressive.
I think one of the big challenges in the future, or one of our big challenges, is cardiac allograft vasculopathy, this chronic rejection process, because that's one of the important causes of mortality. This process is very different from the non-transplant atherosclerotic process. It's a diffuse process throughout the coronary arteries, as opposed to the sort of segmental disease that we see in non-transplant coronary artery disease. And that's why there has to be ongoing surveillance of these patients with some sort of imaging, including coronary angiography, on an annual basis to detect this CAV because if it progresses, it may be that the only way of managing this is retransplantation. And if you've transplanted a child, let's say, and it's important that the parents realise that this is almost certainly not going to be one transplant. This is a lifetime of transplants, and a child over 60 years may require 2, maybe 3 heart transplants, and that would be principally because of the development of cardiac allograft vasculopathy. But it's not inevitable that this happens. About 50% of transplant patients have some degree of CAV by 5 years. So there's 50% that don't. So we've got to understand why some people get it and some don't. There's lots of known risk factors, that are transplant related. Acute rejection, primary graft dysfunction, some sort of injury to the endothelium, and particularly antibody-mediated rejection, and certain infections like CMV is a risk factor. And then there are all the sort of non-transplant-related traditional atherogenic risk factors, hypertension and smoking and cholesterol and so on. That's why managing the whole patient with is so important in obtaining the best survival possible is by by managing all of these factors. There are the immutable transplant factors, but there are all the non-immutable atherogenic factors that have to be looked after: hypertension, cholesterol, obviously, not smoking and so on. All those are important that have to be managed in a transplant patient.
Patient certainly becomes a very important part of the team, and that's why the scrutiny is so high prior to transplantation to choose the right patient, the right candidate that really wants to live and wants to survive and wants to do everything about it. The message that we have here is with all the podcasts that we've done on cardiogenic shock, on new treatments of heart failure, on LVAD, on the cardiac transplantation, is that you can live, with heart failure, and you can live even with advanced heart failure with the right team, the right doctors, and there's more and more ways to really help the failing heart, and I think this really kind of brings a strong message, and a very bright future. I think as future research is still being conducted, and I think new techniques, new developments, and the 3D printing really seems really interesting. Dr. Guichard, thank you very much for your participation today. Dr. David McGiffin, as always, again, a great morning and have a great day while we're going to be, cooking dinner and head to an evening in our part of the world. Thank you, Andrew.
Okay, thanks very much. Thank you, Alain.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.